Hi, I hope you're having a great day. We're going to be talking about antibiotics for urinary tract infections. These are the objectives for the presentation. I'm not going to read them all to you. Okay, UTIs are one of the most common infections in primary care. Among sexually active younger women, 25 to 35% develop at least one UTI a year. Among older women in nursing homes, between 30 and 50% have bacteriuria in any given time. So in my practice, some older women obsess about whether they have a UTI. UTIs occur less frequently in males, but are more likely to be associated with complications such as septicemia or pyelonephritis. In addition, it's often associated with prostatitis. I usually see these with either diabetes, recent surgery, sexually transmitted infections, and prostatitis. So that's in males. Symptoms for acute cystitis, which is a lower urinary tract infection, usually includes dysuria, increased urinary frequency, urinary urgency, suprapubic discomfort or pain, pyuria, and hematuria. This shows the difference in location between upper UTIs and lower UTIs. Uncomplicated UTIs occur primarily in women of childbearing age and are not associated with any particular predisposing factor. Complicated UTIs occur in patients that have symptoms indicating that the infections have extended beyond the bladder. The classifications of uncomplicated and complicated also drive the choice and duration of antibiotic treatment. I see a combination of both complicated and uncomplicated UTIs in my practice. Recurrent UTIs, or RUTIs, are common and affect women of all ages, ethnicities, education level, and socioeconomic status. These infections can reduce a woman's quality of life, and the mental stress of recurrent UTIs can lead to depression. Recurrent UTIs refer to greater than or equal to 2 infections in 6 months or greater than or equal to 3 infections in 1 year. Each episode has resolution of symptoms, and that's considered a separate infection. Most reoccurrences are thought to represent reinfection rather than relapse, even though recurrence is caused by the same uropathogenic strain. Since the pathogenesis of single UTI episodes and recurrent UTIs are similar, with up to 77% of recurrent UTIs caused by E. coli, these infections are treated the same way. Unfortunately, patients with recurrent UTIs, prescribers are more likely to deviate from the treatment recommendations and prescribe higher doses of broad-spectrum antibiotics and longer treatment durations, despite a lack of evidence to support this practice. UTIs can be caused by both gram-positive and gram-negative bacteria, as well as some fungi. The most common pathogen, 75 to 95% of cystitis cases, is E. coli. In hospital-acquired infections, the rate of E. coli infections falls to less than 50%, but community-acquired 75 to 95% E. coli. This is a list of some of the other organisms that cause uncomplicated UTIs, including Klebsiella pneumoniae, Staphylococcus saprophyticus, Enterococci, Group B streptococci, Proteus mirabilis, Pseudomonas, and Candida. Antimicrobial stewardship aims to reduce inappropriate treatment by decreasing broad-spectrum antibiotic use and limiting the duration of therapy. Whether for acute treatment of UTIs or for prevention, recent guidelines provide specific antibiotic recommendations that address growing resistance concerns, as well as collateral damage. Collateral damage refers to the ecological adverse effects of antibiotic therapy. Antibiotics cause changes in the normal gastrointestinal flora that can lead to the development of drug-resistant organisms and the unwanted development of or infection with multi-drug resistant bacteria, including C. diff. Antibiotics including fluoroquinolones, beta-lactams, nitrofurantoin, and TMP-SMX are equally as effective in the management of a UTI. However, ampicillin clavulanate was significantly less effective in producing a clinical cure than other antibiotics. Broad-spectrum cephalosporins and fluoroquinolones are not considered first-line treatments because these classes of antibiotics are linked with considerable collateral damage compared with first-line antibiotics. The selection of an antibiotic regimen to treat an uncomplicated UTI or acute cystitis is based on clinical response and/or urine culture results. For the first infection, I usually do not get a urine culture, but if they come back in again shortly after that, I do. These on this slide are the first-line antibiotics for uncomplicated UTIs and recurrent UTIs due to effectiveness and low risk for resistance. If one of these do not work, try another one before switching to a cephalosporin or fluoroquinolone. That's a very important point. These are drugs where you need to know the dosage and frequency for this class. When a patient is unable to take one of the first-line antibiotics due to allergy, tolerability, or resistance concerns, certain oral beta-lactams are recommended. If those aren't adequate, a fluoroquinolone may be tried, and we have that on some subsequent slides. But first I wanted to go over each one of the 3 preferred first-line antibiotics. Trimethoprim sulfamethoxazole, which I always say TMP-SMX, is recommended for the treatment of UTI as one double-strength tablet, which is 160 milligrams of TMP and 800 milligrams of SMX, and that should be taken twice a day for 3 days. Although collateral damage is minimal with TMP-SMX, the resistance rates are rising, and TMP-SMX covers typical uropathogens and is effective if local resistance rates do not exceed 20%. But even if rates do exceed 20%, the infecting strain can still be susceptible. The most common side effects of TMP-SMX are GI upset, nausea, vomiting, loss of appetite, mild skin eruptions such as hives and rash, and patients should be counseled to take each dose with at least 8 ounces of water and to take photosensitivity precautions. So they should wear protective clothing and sunscreen when outside. Rare serious side effects, including neurological events, can occur, and those might be a septic meningitis, tremor, delirium, gait disturbances, decreased oxygen carrying capacity, which is methemoglobinemia, and blood dyscrasias, liver damage, and serious skin disorders that we talked about previously with toxic epidermal necrolysis and Stevens-Johnson syndrome. Hyperkalemia may occur, and it's more likely in patients with kidney dysfunction, diabetes, older age, or immunosuppression. Drug interactions, including the development of hyperkalemia with concomitant use of a renin-angiotensin system blocking agent such as an ACE inhibitor or an ARB. And hypoglycemia may occur with concomitant use of some hypoglycemic agents. TMP-SMX should not be taken during pregnancy, and during pregnancy with structural malformations, including neural tube defects, small size for gestational age, and hyperbilirubinemia have been reported with taking it during pregnancy. Nitrofurantoin is available in two formulations. The first one is a combination of nitrofurantoin monohydrate and nitrofurantoin macrocrystals, which is known as Macrobid, and this is the one that we usually use. It's typically dosed twice a day for the treatment of acute urinary infections. And then there's a preparation that consists solely of nitrofurantoin macrocrystals, which is Macrodantin, which it's dosed 4 times a day for the treatment of acute urinary infections. But regardless of the formulation used, advise patients to administer with food to improve absorption. So that's a little bit unusual. Macrobid, in a dose of 100 milligrams twice a day for 5 days, is effective with a high clinical cure rate and a low risk for resistance or collateral damage. Although it has a narrow spectrum of activity, it covers E. coli, which is the most prevalent urine pathogen, and also Staphylococcus saprophyticus. A big advantage of Macrobid is that it doesn't cause vaginitis in women because of its narrow spectrum of activity. Nitrofurantoin is contraindicated in patients with a creatinine clearance of less than 60. Limited data does suggest it's safe with a creatinine clearance of 30 to 60 milliliters per minute. And the Beers criteria recommend avoiding nitrofurantoin use in patients who are 65 years of age and older who have a creatinine clearance less than 30. The most commonly reported side effects of nitrofurantoin are nausea, headache, and flatulence, and then there are some very rare serious side effects. There is some urine discoloration, and that can turn their urine dark yellow to brown. For the treatment of UTI, phosphomycin is taken as a single oral dose of 3 grams of powder mixed with 3 to 4 ounces of water. It's effective against multi-drug resistant organisms, including vancomycin-resistant enterococcus, which is VRE, and extended spectrum beta-lactamases, which are the ESBLs. There is low risk for resistance and collateral damage. One meta-analysis showed no difference in cure rates between phosphomycin and other agents, including fluoroquinolones, TMP-SMX, and nitrofurantoin. However, a recent comparative clinical trial suggests that fosfomycin dose is not as effective as a 5-day course of nitrofurantoin. So you're better off picking nitrofurantoin first. Common side effects are diarrhea, nausea, and vaginitis. And it should be avoided if pyelonephritis is suspected. Alternative antibiotics for acute management of a UTI should be reserved for patients who cannot tolerate due to allergy or side effects, or who do not respond to first-line agents, and in women whose urine culture shows in vitro resistance to the preferred antibiotics. Compared with nitrofurantoin, TMP-SMX, or fosfomycin, beta-lactam agents have a higher risk of collateral damage. And remember, collateral damage is the selection of drug-resistant organisms, colonization or infection with a multi-drug resistant organism, higher risk of subsequent infections such as Clostridium difficile. Recommend beta-lactam agents include amoxicillin clavulanate, cefadroxil, cefpodoxime, and cefdinir, and those are all in 5 to 7 day regimens. Cephalexin may also be used, but it's less well studied. Amoxicillin and ampicillin should not be used because due to limited effectiveness and resistance. In general, beta-lactams have less efficacy and more side effects than the first-line agents. Fluoroquinolones are a more effective alternative class than beta-lactams, but have higher resistance rates and a greater risk of collateral damage. Moxifloxacin is not recommended because its concentration in the urine is lower. Fluoroquinolones should be reserved for more serious infections such as complicated UTIs in which higher doses and longer durations are needed. Now remember, with fluoroquinolones, there is a concern about serious adverse events that include seizures, QT prolongations, tendinitis and tendon rupture, peripheral neuropathy, C. difficile infection, and an increased risk of aortic rupture. When first-line antibiotics, beta-lactams, or fluoroquinolones cannot be prescribed, culture and sensitivities should be used to guide therapy. Also, remember that children cannot take fluoroquinolones. Phenazopyridine is available as an over-the-counter urinary analgesic that can be taken to help relieve acute symptoms until an antibiotic is started, or perhaps symptoms resolve on their own. Some common brand names include Pyridium and Urostat and Azo. I haven't heard of Azo before. But no more than a 2-day course is recommended, and it shouldn't be used longer because it could mask symptoms that require evaluation. There's little evidence to support a beneficial effect for phenazopyridine. However, it remains a preferred treatment by many patients. Remember, it should not replace medical evaluation or antibiotic therapy. Common side effects include orange, reddish colored urine, something that sticks out there, headache, dizziness, rash, fever, and itching. It can also cause staining of contact lenses with that orange reddish color. There are some rare but serious side effects, but these appear to be dose dependent, like only with overdose or long-term use. Asymptomatic bacteriuria is the presence of bacteria in the urine, and that's diagnosed with 2 consecutive specimens with isolation of at least 100,000 CFUs per milliliter of the same bacterial species. And they don't have the usual symptoms of a UTI. Women of all ages are more likely to have the asymptomatic bacteriuria than men, and the rate increases with age. So the prevalence about 1 to 6% among premenopausal women and 22% in women 90 years of age or older. So with the exception of pregnant women and patients scheduled to undergo urinary tract procedures, treatment of asymptomatic bacteriuria is not recommended because evidence has shown that it does not prevent asymptomatic UTI. The recommendation for no treatment includes women with diabetes and elderly women. Treatment only promotes antibacterial resistance without preventing recurrences. There is a difference between relapse and reoccurrence. With relapse, there is recolonization with the original infecting organism, and this happens in about 20% of cases. And this probably suggests structural abnormalities of the urinary tract, kidneys, or prostatitis. And then there's reinfection. And this is a new infection that causes a UTI, and this happens in about 80% of females. It usually involves only the lower urinary tract and may be related to sexual intercourse. In 2 clinical trials of postmenopausal women, vaginal estrogen in the form of a suppository or ring reduced the incidence of UTIs by half or more compared with a placebo. So estrogen normally stimulates the proliferation of lactobacillus in the vaginal epithelium and lowers pH. These mechanisms help prevent vaginal colonization with uropathogens like Enterobacter. Vaginal estrogen therapy should be recommended for all peri- and postmenopausal women with recurrent UTIs to reduce risk unless contraindicated. And so the contraindications may be considered for women with a history of breast cancer unless they have estrogen dependent breast cancer. So if they're estrogen receptor positive, they shouldn't use vaginal estrogen. And the decision should be made with the woman's oncologist. Local side effects include vaginal itching, burning, and spotting. Observational and controlled clinical trials have consistently shown that antibiotic prophylaxis is highly effective compared with either a placebo or non-antibiotic prophylaxis strategies, including estrogen, in preventing UTI recurrence. However, there are concerns about potential antibiotic side effects and collateral damage, including a secondary C. difficile infection, and these may outweigh the benefits of reducing UTI recurrence. The effectiveness of antibiotic prophylaxis depends on the ongoing susceptibility of the uropathogens colonizing the patient's vaginal and periurethral areas. It's important to note that there's limited evidence concerning the impact of prophylactic antibiotic therapy on resistance. So this can be administered continuously, so a range from 6 to 12 months, or intermittent before or after sexual intercourse. So the benefit of the antibiotic prophylaxis is only present while taking the antibiotic. So when they stop it, the prior UTI frequency returns. Now, in clinical practice, some women are prescribed continuous or intermittent prophylaxis for years. Here are the recommended antibiotic regimens that have established benefit in reducing recurrent UTIs. There's no evidence that one regimen is superior to another. However, increasing resistance to the TMP SMX among E. coli strains may impact effectiveness. The definition of a complicated UTI has changed somewhat. It is now considered an acute UTI with features that might suggest that the infection extends beyond the bladder. These signs and symptoms include the fever, other signs of systemic illness, including chills, rigors, significant fatigue or malaise, flank pain, CVA tenderness, pelvic or perineal pain in men, which can suggest accompanying prostatitis. If any of these signs or symptoms are present in the setting of pyuria and bacteriuria, I never can get that word right, we consider the patient to have acute complicated UTI and manage the patient differently. Having a structural problem such as those listed here or being immunocompromised puts the patient at a risk of having a complicated UTI, and these patients should be followed more closely to make sure that a simple UTI does not progress into a complicated one. The possibility of prostatic involvement should always be considered in men. Just recently, I had a 54-year-old man who came in with a UTI. Knowing there is likely prostate involvement in men, I suggested that I do a rectal exam. Well, the man had a colostomy and had no rectum. So I didn't know what to do because how could I determine if it was prostatitis or not? So I went ahead and treated it like prostatitis and used a fluoroquinolone. Here's the information on acute uncomplicated pyelonephritis. The fever, flank pain, chills, and other symptoms indicate the disease has spread beyond the bladder to the kidneys and should be managed as a complicated one. I have not had a patient with a severe case, but from what I have been told by my students who work in ER, testing for CVA tenderness will make them fly off the table. Here are the common empiric treatments if the pyelonephritis is not severe enough to require hospitalization. Usually we treat for no more than 7 days. The decision to hospitalize is usually clear when patients are septic or otherwise critically ill. Otherwise, general indications for inpatient management include persistently high fever, greater than 101 degrees, or pain, marked ability or inability to maintain oral hydration or take oral medications. There are other regimens listed on your handout that do not contain fluoroquinolones. Here are the key clinical considerations. Obviously, UTIs are more common among women than men. Recurrent UTIs are greater than 2 urinary tract infections in a 6-month period, or 3 UTIs over 1 year. Symptoms of acute uncomplicated UTI often include painful urination, suprapubic pain, increased urinary frequency, urinary urgency, and hematuria. Fever, flank pain, chills, and other symptoms of systematic illness indicate probable spread of the infection beyond the bladder to the kidneys, and then it should be managed as a complicated UTI. Nitrofurantoin, TMP, SMX, and fosfomycin are the first-line antibiotics for uncomplicated UTI, including recurrent ones, due to effectiveness and lower risk for resistance and collateral damage. Inappropriate UTI treatment can be reduced by decreasing broad-spectrum antibiotic use and limiting the duration of therapy. When first-line antibiotics can't be used, beta-lactams and fluoroquinolines may be considered. And then phenazopyridine may be used as a urinary analgesic, but should not be a substitute for medical care and antibiotic therapy. Thank you for your time and attention.